A 65-year-old man with a 40-year smoking history presents to his physician with complaints of cough, fatigue, and a recent 10 kilograms weight loss. X-ray of the chest reveals a 2 cm hilar mass that is identified on biopsy as small cell lung cancer. On physical examination, the patient has some cachexia but normal skin turgor, no edema or jugular venous distension, and no orthostatic hypotension. Relevant laboratory findings are as follows. What is the most likely diagnosis? Hyponatremia, which is defined as serum sodium concentration below of 135. How is the etiology of this condition determined? Although sodium loss can cause hyponatremia, excessive retention of water is usually the cause. A thorough history and physical examination can help correlate the patient's volume status to a cause of hyponatremia. The cause of loss can be determined by history. For example, vomiting, diuretics, diarrhea, and physical findings of low volume. For example, decreased skin turgor, low jugular venous pressure. Signs of excessive fluid retention include peripheral edema and increased JVP. In this case, the lack of such findings suggests this patient is euvolemic. What laboratory findings can help determine a patient's volume status? Serum and urine osmolarity and sodium concentration. Most hyponatremic patients have a decreased serum osmolarity. However, intravenous mannitol, immune globulin therapy, and hyperglycemia are causes of hyponatremia that accompany normal or increased serum osmolarity. In patients with low plasma osmolarity, urine osmolarity can differentiate primary polydipsia from impaired water excretion. In patients with hypoosmolar serum and hyperosmolar urine, urinary sodium can then distinguish between hyponatremia caused by circulating volume depletion, for example from heart failure, cirrhosis, or hypovolemia, leading to a decreased urinary sodium of less than 40 milliequivalent per liter, and euvolemic hyponatremia, for example, syndrome of inappropriate secretion of antidiuretic hormone, hypothyroidism or adrenal insufficiency, leading to urinary sodium of greater than 40 milliequivalent per liter. A different scenario, the same eager to learn. Let's go to the second part. In this case, what is the etiology of the patient's volume status? SIADH is a paraneoplastic syndrome for small cell lung cancer. Therefore, this patient's small cell lung tumor raises the likelihood of SIADH. Physical findings and lab values are also consistent with SIADH. What are the major causes of this condition? Ectopic ADH production by a tumor, particularly small cell, old cell carcinoma of the lung, intracranial pathology such as trauma, stroke, tumors, infection, a wide range of drugs, major surgery, pain, HIV infection. SIADH may also be idiopathic. What is the mechanism of action of ADH? ADH is the main regulator of serum osmolality. ADH causes water channels, for example, aquaporin 2 of the principal cells of the kidney's collecting ducts to translocate to the cell membrane, thereby allowing more water to be reabsorbed. Its release from posterior pituitary is stimulated by hyperosmolarity and by decreased effective circulating volume. What are the treatments for this condition? Treatment consists of tumor resection. If evidence of SIADH persists or resection is not possible, treatment involves restriction of free water intake, high salt diet and loop diuretics. ADH receptor antagonists such as conivaptan, tolvaptan, and dimeclocycline can also be used. Sometimes hypertonic saline may be needed for symptomatic hyponatremia. This is it. This is our destiny. Again, thank you so much. If you like it, please subscribe. See you next time. Bye.